idiopathic thrombocytopenic purpura in children. Idiopathic thrombocytopenic purpura is the most common cause for the thrombocytopenia in childhood, affecting 4 per millions of children annually. It is characterized by autoantibodies targeting and destroying platelets, leading to a platelet count often dropping below 10. It peaks in incidence between 1 to 4 years of age. Usually, diagnosis is made by exclusion. Pathogenesis. When the triggering factors disrupt the immune system, leading to the production of abnormal antibodies. These antibodies specifically target proteins on the surface of platelets, causing antiplatelet antibodies to bind to circulating platelets and destruct those platelets. In some cases, the immune system may also target megakaryocytes, worsening thrombocytopenia by decreasing platelet production. While their exact role is unclear, T cells may support the activation of macrophages and contribute to the suppression of megakaryocyte function, further affecting platelet production. Causes can be classified as primary and secondary. Primary causes are autoimmune disorder characterized by isolated thrombocytopenia, with no apparent secondary causes or associated disorders. Diagnosis is achieved through exclusion. Secondary causes are, including HIV, systemic lupus erythematosus, antiphospholipid syndrome, common variable immunodeficiency, chronic lymphocytic leukemia, Evans disease, autoimmune lymphoproliferative syndrome, hepatitis C, Helicobacter pylori, post-vaccine and post-systemic infection. Clinical features. Onset typically occurs 1 to 2 weeks after a viral infection. Bleeding manifestations include petechiae, purpura, bruising, epistaxis, gum bleeding, menorrhagia, and melena. Profuse bleeding is uncommon. Life-threatening intracranial bleeding is rare but serious. No other remarkable physical findings are associated apart from bleeding. Phases of disease. Acute immune thrombocytopenic purpura may resolve in less than 6 months, and chronic immune thrombocytopenic purpura last longer than 6 months. Acute thrombocytopenic purpura. This usually affects young children, ages 2 to 6 years old. The symptoms may follow a viral illness, such as chickenpox. Acute ITP usually starts suddenly, and the symptoms usually disappear in less than 6 months, often within a few weeks. Treatment is often not needed. The disease usually does not recur. Chronic thrombocytopenic purpura. Adults have this form more often than children do, and females have it more often than males. The onset of the disorder can happen at any age, and the symptoms can last a minimum of 6 months, several years, or a lifetime. In the investigation, full blood count abnormalities, such as thrombocytopenia, with normal hemoglobin and white cell levels. A blood picture reveals the presence of large platelets, bone marrow aspiration or biopsy to identify atypical features. Additionally, an anti-nuclear antibody test is recommended for assessing chronic idiopathic thrombocytopenic purpura and potential association with systemic lupus erythematosus. Management involves spontaneous resolution in 70 to 80% of cases within 6 to 12 months. For mild symptoms and platelet count more than 20, observation and follow-up are recommended. If the platelet count is below 20, the first-line options include intravenous immunoglobulin and a short course of oral prednisolone. If first-line treatments fail, second-line options such as rituximab, eltrombopag, or romiplostim, azathioprine, or cyclosporin may be considered. Splenectomy is a potential intervention, indicates when the bleeding risk is high or symptoms persist beyond 12 months. Life-threatening bleeding requires immediate attention. Platelet transfusion, intravenous immunoglobulins, and methylprednisolone are used. Parents should have 24-hour access to hospital care and be educated about the disease, recognizing signs of bleeding and understanding drug side effects. Children should avoid drugs that interfere with platelet function and high-impact activities, but routine activities, schooling, and light exercise are encouraged. Chronic immune thrombocytopenia in children often sees a persistent low platelet count after 6 months. Approximately 20% of children with immune thrombocytopenia. Management is primarily supportive, with drug treatment reserved for significant and persistent bleeding, utilizing options such as rituximab, thrombopoietic growth factors, or splenectomy. Thank you for watching. Subscribe for more videos.